We'll let folks roll in. I'll go ahead and get us started. We've only got an hour, unfortunately, but I'm a little nervous excited. So welcome everybody to our Dementia Roundtable event called Seeing Dementia Differently. It's a special dementia panel discussion with some of our wonderful ARC Thames Dementia Fellows who we'll introduce shortly. We also have several folks with lived experience of being a caregiver, a supporter and an advocate around dementia, who we'll also introduce shortly. Wanted to present kind of our event and kind of the reason for meeting today. Uh, this fits in with the Festival of Dementia Research that we held in May of this year. And the whole kind of point of both of these things was to raise awareness about dementia research and lived experiences around dementia. We have this wonderful cohort of Dementia Fellows, and this is a chance, this and our festival in May have been chances to showcase their research topics in a more public space. These have been open to everybody. I even shared it kind of late in the game with our kind of MHL, excuse me, our public involvement, patient involvement kind of family the other day. I think my mom might be here, so cross your fingers for me. That'd be really cool. Um, excuse me. We have our own lived experience in my family right now with some things. So it felt like a nice kind of opportunity. But the kind of core point of this is the people living with dementia have unique needs that should shape the support designed for them. So the fellows, our research fellows here help design the day along with our public folks, our public collaborators, as an interactive opportunity to explore this emerging dementia research. And this is all a part of the NIHR's, the National Institute of Health and Care Research's National Festival of Applied Dementia Research, or DEMFEST. So here we go. Now I'd love to do introductions. Asha, would you like to say hi and introduce yourself real quick?
Yeah. Can you hear me?
Yeah.
Yeah. Hi, everyone. I'm Asha. I'm currently a research assistant working with Esther on a project about equity in hearing aid access. So we're looking at why some people do or do not get hearing aids, even when they might need them, and why some people stop wearing them when they do actually acquire them afterwards. And we've been doing in-depth interviews with participants to understand their experiences. And I'm currently doing the write-up. But yeah, that's just a bit about the project.
Fantastic, Asha. Thank you. Let's go to another one of our fellows. Claudio, would you like to say hi, introduce yourself real quick?
Sure. Hi, everyone. I'm Claudio. I'm one of the Dementia Fellows within NIHR ARC North Thames. So my project is looking at the needs of people living with dementia who live alone and have no support whatsoever. It is recognized to be a very vulnerable population for different reasons. Maybe I'll have a moment to touch on them. But in a nutshell, what we're trying to do is looking at what support is available for these people. And by learning about that, to look at improvements, what we can do to ensure that people who are alone at home can live safely at home independently for longer.
Fantastic. Thanks, Claudio. And I'll go to our last fellow that's here today. Kumud, would you like to introduce yourself? Say hi.
Hi, Will. Hi, everyone. My name is Kumud. I'm a senior research fellow at University College London. And as Will said, I'm one of the DEMCOM fellows. DEMCOM just stands for Dementia Community, which is funded by the NIHR and supported by the ARC North Thames. So my project is really looking at personalized care or person-centered care in people with dementia, specifically from a primary care perspective. So I've looked at what adaptations healthcare professionals make when people are living with dementia alongside other health conditions. And then I'm also hoping to explore in the next few months specific experiences of people from a South Asian community who are living with dementia alongside other long-term conditions. So things like diabetes, hypertension, heart problems, etc. Thank you.
Thank you so much, Kumud. I think that one of our other public folks has had a little phone trouble and has dropped out. Just wanted to point that out. Let me go to Sudhir in the meantime as one of our public collaborators. Would you like to introduce yourself, sir?
Hello, good afternoon, everybody. My name is Sudhir. I'm one of those representative for the North Thames ARC.
And Sudhir, what does RAP stand for?
It's Research Advisory Panel.
Thank you, sir.
So, or I would call it a Research Advisory Panelist.
Fantastic.
Okay.
Thanks.
I'm a carer, and I've been caring somebody with dementia. So I will be talking about my experience of dementia as a carer. That's me, Sudhir.
Thanks, Sudhir. Let me go to Joan next.
Okay, I'm Joan Manning, and I've been working with Sudhir for quite a long time. I was a carer for my husband. He had dementia and heart problems and cancer. So I had quite a long time with him. And we got involved with clinical research through him and through Queen Square. And that's why I'm here today.
Thank you so much, Joan. It looks like Val is still with us. Val is calling in on the phone, so you won't be able to see Val, but you should be able to hear her just great. Val, would you like to go ahead and introduce yourself?
Thank you. I'm Val. I care for people with dementia, and I cared for my husband who was disabled, but luckily didn't have dementia. And I'm a PPI member.
Thank you so much, Val. It's great to have you here. So we got our sessions separated in kind of themes, and so I'll call on people kind of as we go along. And as some housekeeping before we jump in, please check your audio-visual settings before we begin. Make sure that you're muted when you're not speaking. Please be sure to use the chat and ask any questions or make any comments. We'll try and work these in as we go. We'll have 10 minutes at the end for questions from the audience. And also we'll be recording this event so that we can kind of spread it more widely and kind of help keep the conversation going and help help more broadly share all of this, all these thoughts and research. So just to recap, we got 10 minutes for kind of joining and introductions. Then we'll discuss for 30 minutes and we'll have about 10 minutes for Q&As at the end. So our first section is on motivations. And this one is going to be especially for Kumud and Joan. So starting off, Kumud, what motivates you to work in dementia?
So dementia is actually a growing public health problem, not just in the UK, but across the whole world. In fact, across the world, we've got right now 55 million people who are living with dementia. And within the next 25 years, that's going to grow to 150 million people that are living with dementia. So there are certain groups we know where dementia is more of a problem. So for example, in the UK, we have a lot more women who have dementia compared to men. So around 60% of women have dementia in the UK compared to around 40% of men. And this is likely because we have women that are living longer than men, but we know that age is also another factor that is a risk factor for dementia. We also know that there's a greater prevalence of dementia among minority populations, so people with Black ethnicities or South Asian ethnicities, they have a greater prevalence of dementia. So in fact, right now we have about 25,000 people living with dementia from Black and South Asian backgrounds. This will increase to over 175,000 by 2050, which is a 7-fold increase in the number of people from a Black and South Asian background that are going to be living with dementia. And unless more public health interventions are put in place, the estimated numbers are going to steadily rise. So my motivation really is to see what we can do to help reduce the number of people that actually get dementia. And for those that do eventually get dementia, how can we better support them is my number one motivation in researching dementia.
Thank you so much, Kumud. Nira posted a chat, said that figure is scary. I definitely agree. I think it's hard to kind of think of it as not scary. Thanks for a great start to this and kind of helping us realize and note how serious it is. Um, I am taking notes. I will try and come back to a couple tiny questions that I might have. Uh, but Joan noticed something as we were kind of prepping and working on all this together. So we had several prep meetings to kind of talk about topics, how the flow would work, that sort of thing. Joan, what was the thing that you noticed about um, age in our kind of crew here?
I could not get over how young the people doing research, the age of, the young age of the people doing research. And when I was young, it wasn't anything that ever came into my life, into my mind, into anything. If somebody was old and a bit nuts, they were old and a bit nuts. We just accepted it. And we didn't think twice about it. Nobody would have thought about researching into it. I was so impressed by the interest that they were showing, the questions that they were asking. And I still don't understand what draws them, because it's not the most glamorous of research subjects.
Yeah, the it in this, of course, is dementia, right? You couldn't understand why
No,
young
no,
folks would want to study dementia.
yeah.
Yeah. And so, Kumud, why do you think there's so many researchers and why do you think that so many of y'all fellows are younger folks? What do you kind of say to Joan's comment about this?
Oh, that's very flattering. I don't consider myself young, actually. But, I think
I
what
do.
it is, thank you, Joan. So I guess the thing for me is that over the last few years, there's been a lot of work done in dementia research. And because of that, we've got a much better understanding of what the problems are in dementia and how we might make improvements. For example, we now know that there are 14 different risk factors for dementia, and a lot of them are actually modifiable, meaning if we do something and change some things, then we might actually reduce the risk of dementia. But alongside our increasing knowledge of the disease itself, there's been a lot of major advances in technology and also access to data. And I think this is what might be something that's drawing people to focus their research on dementia, but also because of all these intersecting things like the greater advances in technology and access to lots and lots of data. We're also finding that it's a really lovely opportunity to actually work together in different teams. So multiple professionals are coming together to try and address specific research problems. And I think that's what draws people together. It's these different things that are coming together, which is going to help us resolve some of the problems. Maybe not find a cure for dementia just yet, but actually do research to improve the lives of people living with dementia, but also for their carers as well.
I'm extremely grateful. And I was so impressed with the quality of your researchers and the research that they were doing. I thought it was really interesting. I just wondered, maybe they've got grandparents who've got dementia, or because we're all living to be older, they're actually coming more into contact with dementia. But really, I was involved with clinical research with dementia nearly 20 years ago when there was practically nothing doing. And I was impressed even then at Queen's Square with the team who were there. They were all young and they were most glamorous lot. My husband called them his girls. They were so glamorous. And we were as much impressed with the research that was being done, was the interest and in the actual health of the patient, which he wasn't getting anywhere else. Before you do any research, you have to find out absolutely everything about the patient. You don't get that if you don't go into clinical research. And the quality of the care, the quality of the interest is still there. I know, because I still see his consultant on television sometimes. But even then, I was very, very, very impressed with the youth of the research who were doing this work.
I think there's a lot of poetics to that. Thank y'all both for all those contributions. I wanted to say, Joan, I think you might have started to get there on your own. But I wanted to say, Joan, specifically, what motivates you to do public involvement work on dementia?
Well, it was my husband, obviously. My husband was diagnosed nearly 20 years ago, and in those days, you had a good relationship with your GP, and your GP knew you. And it was he who picked out that my husband, who was an athlete, he was a runner, he was a nice guy, he did everything you're told to do not to get dementia, and he got it. We think maybe from a blood transfusion abroad, but that's another story. The consultant said he couldn't do anything for him. This is 20 years ago. So he got sent to Queen Square. They said, if you like, there are some people looking into it. So we were sent up to Queen Square, and he was their patient till he died. And I was so impressed with what they were doing. And then they, knowing my background, used to say, would you read these papers through for us to make sure that the other patients can understand what we're writing about? So I got a little bit involved on the other side of it as well. But I thought that was my introduction into proper clinical research. And I was totally and utterly impressed with the care that is given to the patients. You cannot buy it privately anywhere. The quality of the knowledge of the doctors and the professors and the nurses and everyone that was looking after them, and the respect that was given to the patients, which he wasn't getting anywhere else. So that's what actually started drawing me into clinical research.
So it was kind of an engaging environment.
Totally.
It kind of surprised you, it sounds like. Is that right?
It astonished me.
Yeah.
I thought it would be all these scientific people behind doors, and it wasn't. They are friendly, they are kind, you are part of a team, you're part of a family, and they include you in everything, and they ask you, you have the options to jump out if you don't want something, or if you don't like something, you want to know something, you ask them, they'll find out for you. You've got a different sort of problem, is it related? You go up there, they'll find out for you.
Yeah.
We didn't get this anywhere else. It was amazing. We didn't get it with his cancer treatment. We didn't get it with his heart treatment.
Wow, that's a really interesting contrast. But you had it with the dementia.
We had it with the
care.
dementia group, and a lot of his other treatments were put to one side by the other consultants because he had dementia.
Yeah. That's amazing.
So he didn't get certain treatments because he had dementia.
Yeah.
But Queen Square made sure he did. They looked after the whole bit of him, as well as his dementia bit. They made sure that anything else that was wrong was seen to.
That's fantastic. So I'm going to pivot a little bit. Kumud, I'm going to put you on the spot real quick. Kumud, can you tell us, I don't know, 10 words or less kind of internet definition. I mean, a valid internet definition. What is a risk factor? You said there were 14 risk factors for dementia. What is a risk factor?
A risk factor, in simple terms, the way I understand it, is something that increases your chances of, in this case, getting dementia. So some of the things that I said are things we have control over. These are modifiable things. So things like our diet, we have control over what we eat. We have control over how much exercise or how physically active we are. But there are certain things we don't have control over. So our age, everybody ages. We don't have any control over that. Sometimes it's our genes as well. We don't really have any control over our genes. So these are some of the risk factors. So other risk factors include things like hearing. So if you have poor hearing, again, you are at a higher risk of getting dementia. Some other conditions as well increase your risk of getting dementia. So things like diabetes or heart problems. Now, there might be a genetic element. So for example, I'm from a South Asian background, and it's quite well known that people from South Asian backgrounds have an increased risk of getting diabetes, for example. So I have diabetes in my family history. So both my parents had diabetes, so I'm at risk of getting diabetes as well. That's not something I have control over. What I do have control over is maintaining a healthy lifestyle. So eating appropriately, not eating too many carbohydrates, for example, so sweets and chocolates and cakes. So having control over that, making sure that I exercise and lead a healthy lifestyle, maintain my physical activity, for example. So I hope I've answered your question in
Absolutely,
a simple
absolutely.
way.
No, that was fantastic, and it really connects to kind of Joan's examples where her husband was very athletic, was very
Yeah.
healthy, was doing exercise, was eating right. But there were also kind of lots of references to age, which you mentioned earlier, and which has actually been popping up in the chat. Nira, I thank you so much for your hand, but can you hold it until the very end? Well, I'll make sure I see your questions in the chat. I'll make sure and I promise that we will let you ask some questions. I've got to jump to our next part, which is on misconceptions of lived experience. So we'll do Claudio and Sudhir in this one. So Claudio, first, what do you think the misconception, which misconceptions about dementia do you think are most common?
Okay, well, so thanks for the question. I think it's an interesting question. I would start by saying that the word misconception means that we have preconceptions about something and about dementia in this case. And I think that preconception is a misconception in the first place, if that makes sense. Because I always say that dementia has some very general commonalities across the board, but it's like saying that all Italians, like me, are the same, which I hope is not the case. So what I'm trying to say is every person living with dementia is their own person. Each person has their own stories, experiences, backgrounds, and as a result, needs as well. Dementia, I think, is just an added layer on top of all these characteristics, but obviously it does not define the person. So going back to me, I'm Italian, I'm a gay man, I'm an academic researcher, I'm an anxious person, but most of all, I'm a synthesis of all these things. And a person living with dementia is the same. So I would say usually as much as you're open and curious about getting to know a new person, say, for example, you're meeting a friend, a person who could be your potential new friend. You meet them for the first time, you're very open and curious. I think it's that curiosity that should drive you to interact with a person living with dementia, whether you're a researcher, you're a person meeting them for the first time, and actually, every other time you meet them, you have to have that curiosity going because we all change as humans. We're never static. So our preferences, aspirations, needs, and also our care when it comes to dementia will change over time. Just to really sum it up, I'll give you a practical example from my own research so that it gives some context. So we tend to assume that everybody living with dementia has somebody who supports them. Just have a think for a moment. I know everybody's muted, but just for a moment, have a guess. Out of 10 people, how many live at home alone? Just for a moment, I'll give you the answer. It is 3 people. It's actually a lot. And of these 3 people out of 10, up to 10% do not have anybody at all supporting them. So for a moment, can you imagine what that means? It means nobody reminding you to take your meds, nobody to help with meals, personal hygiene, cleaning, washing, transport, come and go to appointments and community activities. And then most importantly, you haven't got anybody to support you with your care arrangements, your finances, your social care, and all those risks that not having that in place entails. So, so really, you do have lots of preconceptions. We just need to focus on the fact that every person is different from the other. That's what I always say when I speak to people.
Thank you so much, Claudio. Joan chimed in, it's hard enough being alone without dementia. I really appreciate that as that's a great lesson, I think, for all of us to learn. I imagine for those of us to remember who spare a fair amount of time in a dementia related context. Um, It just feels like a great lesson. Sudhir, let me pivot to ask you something. What do you think that we can learn from lived experience about dementia? Or what can lived experience teach us about dementia that researchers can't?
Yes, a lot of practicalities. I'm a carer with some years of experience for looking after somebody with a dementia. It taught me a lesson to say that as a carer, I have to be prepared for unexpected challenges. The challenges were behavior condition changing, so you have to prepare for it. One of the things I found that dementia is unpredictable, i.e., what you think is happening may not happen, and sometimes can be opposite. It is good to be open and honest. Seek help from the family and organizations like Dementia UK, etc. Being transparent and open may get rid of some of the taboo subjects, because I suffered that with my family members. And I was just pursuing that we had to be open and honest, but some of them wouldn't do that. And some memories wouldn't merge from that. They wanted to keep it secret so that other people don't know about it, which in the end created a chaos. So my best advice here is that if you are struggling, is to seek help. And one of the area you can seek help is Dementia UK. They're a wonderful organization. And they offer a lot of support. They use Admiral nurses. They provide advice, practical solutions, emotional support, because emotional support is a lot required. As we are caring for our loved ones, we need that. And that is very helpful. And there's also some guidance on advocacy, because when somebody gets the worst part of dementia, you need a power of attorney so that the financial and the other things are looked after well. So this is the advice I can give, because those things you can't get from the research. This is something you learn practically. Remember, many years ago, there was no dementia. It's just recently a lot of people are getting it, and a lot of people are not prepared for it. So my advice is, how do you prepare for it? Well, one of the few organizations are there which can help you, which I mentioned again, Dementia UK, Age UK, and there is also local carers. Because my local carers, they do organize dementia evenings or dementia day and help them what they're expecting. And then they learn from other lived experience people what they're going through it. So there are many organizations now branching off to help dementia. Because in my local care, there is a big writing, dementia, we help. We can, if you need help, call us and we'll help you. So I'm sure there are other organizations do that. GP practice, they do help, but probably, as you know, it's difficult to get a GP appointment. They give you only 10 minutes of their time and you can't get much out of it. So it's like, remember, when we have a mental health, we used to go to Mind. They used to help out more. The same thing with dementia. Dementia UK do help a lot. So this is what I think.
Thanks, Sudhir. That was wonderful. I really appreciate that. The it sounds like the core of what you're saying is if my question is what can we get from lived experience that we can't get from research? It sounds like you kind of flipped it and you said this is what this is what lived experience can offer for research. This is what yeah, this is what it can offer research. I'm kind of thinking out loud as I do this. Um, it sounds like your answer to that is support. Like it reminds me of what Joan was saying, where in order to do good dementia care or dementia research, there has to be some kind of inclusion of support based on meeting people where they're at and understanding what they have to say. It reminds me a lot of what Claudio said. That any preconception is a misconception. That there are things that overlap in dementias, but each dementia is different. Does that sound right to you, Claudio? I mean, do you hear those kinds of things in what Sudhir is saying?
Absolutely. Yeah. And if I can just very add something quickly to what Sudhir
Absolutely. Go
was
for it.
saying. Yeah. You brought Sudhir, you brought up the example of Dementia UK, which is a great organization to ask support to. I know that recently they've actually just hired a new person to be the admiral nurse for LGBTQ plus communities living with dementia. So when we talk about all the difficulties and the other challenges that some communities, Kumud also mentioned South Asian community, they experience in accessing services, but even just merely seeking support, which is a big thing for lots of people, given how historically they've been treated by, care services and society. It's very important and refreshing to see that these organizations finally are starting to understand the unique needs that certain communities experience. And Neil just mentioned in the chat that rural communities obviously have added layers of challenges in getting away from that social isolation that they experience. So it's important to consider, as we said before, the individual aspects of everybody. And at the same time, just to really echo what Sudhir was saying, seek help because there's also culture relevant help out there.
That's a great kind of note to end on. I really appreciate all of y'all who've spoken this far bringing in kind of specific details about different communities and their kind of more unique needs around dementia. Thank you, Neil, for pointing out it's even harder being alone and gay. I think that really relates strongly to what Claudio is talking about. Like the unique needs of LGBTQ plus communities and peoples and identities. Let's move on to our last section. I appreciate y'all's grace and how well y'all are able to kind of talk to each other's points. Our last one is on challenges. So we're gonna give the first half of this one to Val Shaw, and then we'll bounce between Claudio and Kamut. And I think we already have a question about hearing for Asha for the very last section on audience questions, but we'll have more audience questions, I imagine. So Val, can you hear us? Val's on the horn.
Can you hear me?
Fantastic. I can hear you loud and clear. Somebody wave your hands if you can hear Val. Great. Thanks, Kamud.
Lovely,
Like to see
thank
those
you.
hands. So Val, I wanted to ask you, what do you think the challenges and rewards are of collaboration between researchers and the public around dementia?
What are the challenges and rewards? A lot of the medical staff, I'm not saying you're researchers in your line at all, but I've come up against challenges with some medical staff who think they're very talented in their work, but they maybe are a bit above me and don't want to work with the public, this sort of thing. So yeah, I've had challenges like that, and they don't always listen to, when you go to appointments or things with a dementia sufferer, they don't always take the carer. The carer knows that dementia, the person living with dementia, better than anybody else in the world, and they don't listen to the carers, what they're saying, and, they knock them out, this sort of thing.
Sorry, I was just taking notes and hunting for my mute button. I'm really sorry about that, Val. I appreciate you. It's hard to talk about challenges. And I know that there's a lot of researchers on this call, and there's a lot of NHS related people. Appreciate you being brave and talking about those. It's always, but there's and I hear the kind of hesitation, but don't let it get to you, because we need to kind of hear these things as a whole kind of community of folks around this. You've been involved pretty consistently throughout the process of this of these dementia activities that we've been doing for the last couple of months. What are some of the the good things about it for you? Like, what do you think are some of the rewards that you've gotten out of this? So like this event today and like the thing we did in May, and even just the kind of chats that we've had over the last few months about all this.
Yeah, I'm very grateful to you all for listening to what I've had to say, because I'm trying to get a voice out there for people that can't speak for themselves, or are not being heard, put it that way.
Yeah.
And I'm really appreciative about how you've all listened to me and made notes of things and taken it on board. I can't praise you enough. It is really lovely, sort of thing.
Thanks, Val.
And I just like in May and today and every time I've spoken to you. And sometimes, I'm not being political here, but sometimes local governments and that, their social care departments need to listen to you and learn by you as well.
Yeah. I appreciate that, Val. It's really interesting because I kind of hear, so Joan's experience with her husband had a lot of praise for the unique kind of powers and strengths of dementia-focused care. But it also sounds like you've had some kind of opposite experiences. So I think it's really powerful to have kind of both of those things across the spectrum in the same discussion, in the same place. And for us to remember that they can be good and bad. That's powerful. Thank you. I want to pivot now. I'm kind of watching our clock. So Claudio, first for you, what are the challenges and rewards around PPI, around collaboration with the public that you have had, that you've experienced? And let it fly. Let it fly. You know, you can change the names to protect the innocent. But
Okay, so first thing I wanted to just acknowledge what Walt was saying about the importance of mutual learning when it comes to the process of care. That's actually quite key. And actually, it also translates when it comes to collaborations between researchers and the public. We're actually there to learn from each other, and by learning from each other to build on the evidence and the impact that we can make together, only together. So in terms of, let me get to your question. In terms of I'll start with the challenge. I'll start with the challenge and I'll finish with the nice thing. So I actually spoke about this at the early career researcher event that our ARC held 2 weeks ago in London, because I think it's quite important. For me personally, one of the great challenges is to always negotiate and balance what's possible and what's ideal within a research project. So I'll give you a practical example. I was recently awarded 10K by the UCL Grand Challenges Initiative to do some research in LGBTQ plus communities living with dementia. This may look like a lot of money, but actually for what needs to be done to redress the huge inequalities that my community experiences when faced with dementia, it's actually just peanuts. It's very little money. So of course, when you're working with committed and passionate and vocal advocates with lived experience, they will come on the project with their own aspirations and views on what needs to be done, which is actually what drives the whole thing. But I've always found myself struggling to begin with, but eventually also learning how to negotiate that. So what I tend to do is I try to be kind of realistic, not to raise expectations too much. Just be real and realistic from day one, not over-promising, but maybe suggesting that it's baby steps, but these are still steps towards something that's much bigger. And actually, these baby steps are necessary to build up that evidence and credibility to then get the big money. So that is about the challenge. I think for me, it's negotiating what you can do versus what you want to do. And shall I touch quickly on the good things, or do you want to ask Kumud first?
let it rip.
Okay. So the reward bit for me easily outweighs the challenges. And I could summarize it into the concept of impact. So I think impact, it's on many levels, but maybe what I can focus on here is the actual immediate impact on the actual partners, the PPIE people with lived experience that collaborate in a project. Now, maybe as a short background, I should explain that within that project that I talked about, on dementia and LGBTQ+ community, we created a final exhibition event where we showcased some comic strips illustrating the personal life stories of people from LGBTQ+ communities living with dementia. And these comic strips were designed by a visual artist, but completely based on what the community partners wanted them to look like. So we just went to the partners, asked them, tell us your own story. And we started from that to design the characters, the colors, the content, everything about it. And the final product was just amazing. So just to see in the eyes of the partners, the pride, the power, the validation of seeing their own life on an art, display was for us researchers the greatest reward. So I think when people can tell their story, especially from communities that have experienced trauma, it almost becomes cathartic. It almost becomes healing. And I think this alone was worth all the efforts that were made to get the funding. Just to finish, Will, very quickly, I just wanted to say that the collection of these comic strips is now being made into a little book, and of course in a digital format too. So anyone who's interested in that, it's about to come out, so let me know and I'll be sure to send you a copy.
That sounds like a very exciting and wonderful, I don't know, I don't want to call it an output. I mean, what's the, I don't know, thing to come out of
Fair enough. I'll
we
put
can
it.
call
Yeah.
it we can call it an output. I was trying to think of a more public term, but on that note, I want to read one of so Joan offered her own challenges in the chat. I want to read this out loud, and then I'll go to Kamud. Joan's challenge on the PPI side is language. So researchers speak their own language and don't always realize it is a different language from that of patients and carers. A lot of effort has to be made in communications, just speaking in ordinary everyday languages. I can't think of a word for outputs right now. So so even though I'm supposed to be the kind of bridge between these worlds, it's a great example of the challenges. So thanks, y'all. Let me go to Kamud. Kamud, same. I guess I should say it out loud again, shouldn't I? What are the challenges and rewards of collaboration between researchers and the public for you?
Thanks, Will. I think just to come back to just what you were talking about just now about output. For me, I would see an output, if I were to explain it in a lay term, is like, what was the end product? What resulted, or what was the end product of the collaboration or the co-production or the discussions that you had. That's what I would say. But in terms of challenges, it's pretty much similar to what Claudia has already said. This thing around managing expectations is quite a challenging thing. So it's expectations that you have as a researcher, but then it's also expectations that the people you're working with have. So it's very important to make it very clear from the very beginning what you, as a researcher, what you're looking for from the people you are working with, but also for them to have the opportunity to say, okay, is this what you need? Is this how I can contribute? And if it works for the two parties, then you go ahead. I guess what I'm trying to say is trying to find the right people to work with you is not always easy. When I say the right people, it's not that anybody we're working with is right or wrong. It's just, have they got the time to work with you? Are they able to do the things that you would like them to do? For example, if you need somebody to fill out a form every week for 6 months, that might not be something that people can commit to. I know that's quite a, exaggerated example, but it is those kinds of similar things. So managing expectations is one key challenge. And then the other one is around resources. So it's either time resources, so not underestimating the time and the commitment required to do pieces of work, but also resources in terms of funding. So, we would like people to help us with our projects, but at the same time, we need to remunerate them or give back what they give to us. And the NIHR, so the National Institute for Health and Care Research, has set out some guidelines about what we should be paying members of the public for their time and effort and commitment. So, sometimes Claudio touched on him getting some funding to do a piece of work, and he was saying it's peanuts. But sometimes researchers don't have any money to give to members of the public to help. So for me, those have been some of the key challenges. But the reward, on the other hand, has been learning from people with lived experience. And a classic example is actually me working with Sudhir, who's on the panel right now. So through my discussions with Sudhir, I was aware of some of the challenges faced by carers of people living with dementia. So these are, things that you read about in the literature. These are widely known, so carers being lonely, carers being very exhausted from supporting their loved one who has dementia. But what Sudhir taught me was that for families from a South Asian background, there are additional levels of complexity that even though I'm from a South Asian background, I had not appreciated. And Sudhir already said this, it's around some family members wanting to tell their community that, yes, their loved one has dementia, whereas others want to almost keep it a secret. And there are obviously reasons why people might want to do that. But unless and until awareness is raised about dementia and how it impacts not just the person with dementia, but their carer, but not just the carer, the wider family unit, we're not going to be able to make those steps forward to support everybody that is affected by dementia. So for me, working with Sudhir has been really, really beneficial in helping me understand the nuances of caring, specifically from a South Asian background. And he's actually shaped my next project. So I said at the beginning that I'm looking at person-centered care, specifically from a primary care perspective, but I am looking at people living with dementia alongside other health conditions. So what I want to understand now is what are the experiences of people from a South Asian background when it comes to living with dementia alongside other health conditions. So the reason for me doing this project is because we know that people from South Asian backgrounds are already living with multiple long-term conditions, diabetes, hypertension, heart problems, depression even, right? And if you throw in dementia on top of that, it just adds a whole other level of complexity. So I want to try and understand what people's experiences are specifically from a South Asian background and those living with dementia and other long-term conditions, which I'm hoping then will give us a better understanding of what services are required specifically for those populations. So working with Sudhir and other members as well. So it's not just Sudhir, I've also worked with other PPI members or patient and public involvement members who have all shaped this next stage of the research that I'm going to be embarking on within the next few months.
Thanks, Kumud. And thanks everybody on our panel for their points. Y'all also have amazing timing. I wanted to move it, so we'll go ahead and move into our audience questions now. I wanted to start off with a couple of questions for Asha, if that's okay with Asha. So Asha, first, what motivates you to work in dementia research? Why dementia as a topic, I guess?
Yeah, sure. Well, for me, I think it's more of a personal reason, just having a granddad who has dementia, also in the South Asian community. It's not a big thing to talk about, as as it was just said. But I think, well, I just sort of came out of education just now, like last year, and I took a dementia module, which I didn't expect to enjoy as much as I did. And I think from then, my interest in dementia really stemmed. And yeah, like I said, the personal reason as well. It just makes you want to just learn more about it, just to help those around. And also, I think seeing a lot of the things I learned in my granddad right now was quite eye-opening. Because you can learn it, but actually seeing it in real life makes a big difference. So I think that was my motivation. Yeah.
Thanks for sharing, Asha. That's real. There's a lot of that's really beautiful. I also like relate to that in a really personal way. I mean, so my aunt right now has dementia, and there are things that I have learned from all of y'all in the course of this project, and of course of doing more on dementia with y'all, that I took home with me recently, and that impacted and affected how I interact with my aunt. It helped me kind of like have a lot of understanding that I didn't have before.
Mhm.
So I definitely understand. I wanted to kind of use that to make a point for kind of everybody that um, lived experience and research are not necessarily these discrete categories. I think they're divided by things like language, um, but I think they're very kind of tied together and very kind of interlocked and interwoven, especially around dementia. Um, there's a lot of y'all who have personal, but there's a lot of y'all on the fellows side who have these personal, very personal connections to the dementia world. Um, and they're all of y'all who are here from a lived experience side are obviously very involved with the research. Um, I think there's this very common goal of wanting to do something about it together. Asha, there was a great question in the chat that's related to y'all's project
Yeah.
about hearing. I gotta find it real quick. What is the medical connection between hearing and dementia?
Yeah. So as it was mentioned earlier, hearing loss is one of the 14 risk factors, modifiable risk factors of dementia. And it was found that for every, this is in the Lancet Commission report, so for every 10 decibels of a hearing loss, there's an increased dementia risk by 16%.
Wow.
And yeah, and a lot, like around, I think it's around 60% or around 60% of people worldwide have hearing loss over the age of 50. And it's often left untreated, which obviously isn't great. And I think with the hearing loss, you know, by not being able to hear, you're not really communicating often, you're not interacting with people, and that can have effects such as, reducing sort of cognitive stimulation in the brain and engagement. And I think that's sort of the connection to dementia risk. But like what we're doing right now with our study, hearing aids are seen as a protective factor. So people with a high risk of dementia who use hearing aids, there was a trial that found that it reduced cognitive decline. Using hearing aids reduced cognitive decline for what was it, around like 48% over 3 years. So I think that's why we're doing our sort of research on why people uptake hearing aids, why some people don't uptake hearing aids. And we're sort of looking at people with like a low sort of socioeconomic background or people living in rural areas, as said before, because I think it's quite hard to access hearing aids when you're kind of from those two backgrounds, especially. So that's what we're kind of focusing on. Yeah, don't know if that answered the question about the.
Absolutely, Asha.
Yeah.
Thank you. You had a line in there about rural communities towards the end. I
Mhm.
wanted, so Neil Cutler is one of is in the audience today. He had a lot of awesome chats. I'm not going to ask you to talk, Neil, don't worry. He had a lot of awesome chats that were going on just because of the time restrictions. I usually like to read chats out loud. Neil said that he is a carer of a relative who has dementia. He said this was earlier before it had been mentioned, but he said in LGBT communities, which are about 10% of the population, in the main, their lives are scary when dementia sets in, as it puts them back to difficult times. Is it possible to talk about this? Neil, I know that we talked about this a bit more after you said this. I just wanted to, did we get to the parts of that you wanted to hear about, or would you like to ask another question about it? To kind of help frame. You're welcome to chat it if you like, and I can read it out loud. We've probably got time for about one or two more questions. We've got about 4 minutes left. Let's see. I wanted to kind of look through some more chats real quick. To Tony Collins Moore said LPA is a game changer. I don't know what LPA stands for. Tony, if you want to put in the chat what LPA stands for, that'd be great. Neil also said he feels that. Neil said that he feels that we're all in London or big city residents try living in a more rural community. That I think that's probably the case. In Neil's experience, one of the challenges is getting people to admit that they're living with dementia, as it is a mental health condition, and mental health is in this country does not get a good press. Let's see. LPA is lasting power of attorney. Thank you, Tony. Let's see. Just looking. Sean says we call it leaky brain. 24/7. So Sean DeBoy also said 24/7 care for mom has been very lonely until we established social networks and activity. Trying to get her to use a hearing aid has been the toughest battle. And y'all call it leaky brain. Thanks, Sean. I didn't hear it. I don't see any more questions from you, Neil, so I'm gonna move on to another one. Let's see. I don't know. Oh, Sudhir had one. Sudhir had a question for the researchers. I would like to hear from the researchers whether it is possible to provide the solution or advice via research on emotional and behavioral issues. I guess associated with dementia. Sudhir, you can shake your head. Yes. Okay, cool. So yeah, do you think that? So I guess the question is, researchers, do you think that research will be able to provide a solution or advice on emotional and behavioral issues associated with dementia? Is that your question, Sudhir? Shake your head, yes.
Yeah.
Okay, great.
I agree, but it's not easy to answer that, because you can get the answer through co-production and getting the whole community working. But I'm wondering, through research, is it going to be via co-production research, or is it going to be a different way of looking scientifically? Just wondering.
A great question. Would anybody like to answer that? I'm sorry if there's a lot of noise coming from my end. There's lots of chaos in the street where I am.
I don't really have an answer for Sudhir, because that's a really challenging question. But I am aware that they are looking at this from two different perspectives. One is the co-production route, where you look at the whole person and all the different challenges that they experience, and then working with people affected by dementia and their carers, try and find solutions that will minimize the behavioral impact. And then on the other hand, although this is definitely not my field of research, there are scientists looking at specific pathways in the body system and the brain that might be more affected compared to others, and see if they can find a way, maybe using drugs, to try and alter those pathways to then make sure that the behavioral changes are either gotten rid of or minimized in some way or made less in some way. So I'm not sure if I answered your question, Sudhir, because it's really not my area of expertise, but I am aware that there is some research being done in the area. It is very challenging, and as many have already said in the panel, every person is unique. So it affects, the different symptoms affect people in different ways.
Yes, I agree. That's why I thought it was very challenging, because you can't individualize, because what you find out may not work with others. I know there are certain scans coming up, or good scanners, to look at, see how the electricity within the brain and the behavior and the nerve system works. Whether that can be done, I'm not sure. It's beyond me, but whether that research will be done in future, I don't know. As more and more people are getting dementia, and the one biggest issue I found is the unpredictability, and that was due to the behavior. And it becomes very challenging to look after somebody. So I can't give others an advice that, look, I found this way. It may work for you, may not work. So it is a challenge. See how in future you can benchmark to something which is, I think, is impossible. But if you can, it'd be great.
Just to add to that, Sudhir, you just reminded me, I was at a meeting last week where a researcher from UCL is actually doing some work on behavioral change and in people with dementia. And they're using some fancy techniques and fancy ways of understanding why people react the way they do. It's not something I'm involved with, but there is some research definitely being done around this.
Great. Thank you.
Thanks, y'all. There's way more chat. There's way more chats. There's way more questions than chats, or way more questions than we have time for today. I'm so sorry that we didn't get to the other ones. Thanks to Neera for all of her engagement with the chats, especially around the research and the science. Thanks to, let's see, where are they? Neil, Sean, and Tony for their support of different dementia support groups, and for their kind of willingness in the chat, especially from Neil around the LGBTQ plus communities, and kind of giving more platform and voice to voices. I gotta close this out, y'all. I know that there's more questions, and I feel like we could keep doing this for another half hour though. But I will let everybody go. Does Sylvie or any of our organizers have any kind of ending notes or final word for us? If not, it's okay. Because I can roll credits. I guess that's it. Michelle says many thanks. Keep going. Nothing from Sylvie. Thanks, y'all. You were a wonderful group of very engaged participants. Thanks to our public folks for all of their teamwork on this. And thanks to the researchers for opening up a platform where we can do this, and for y'all's really strong kind of commitments to public dialogues and teamwork like this. Thanks to Sylvie and Katie for organizing. And to our other PPI folks who came. Y'all take care, and we'll see you soon.
Thank you for sharing, Will. Well,
Thanks, Claudio.
Well
Thank
done.
you, Will. You
Thanks,
can
all.
you can go to bed now.